Hello everyone. In this particular session, we are going to talk about the physiology of heart sounds. So when you place your stethoscope on the chest, you are listening to the mechanical events of the cardiac cycle translated into sound waves. These sounds mainly come from vibrations caused by the valve closure and changes in the blood flow, but not from the valve snapping shut themselves. So there are two normal sounds, S1 and S2, that frame the cardiac cycle, and two extra sounds, S3 and S4, that may be physiological in some individuals but are often pathological in older adults. So let's talk about each heart sound quickly. First heart sound. So first heart sound is also called as S1, which marks the beginning of the ventricular systole. So this sound occurs when the ventricular pressure rises and exceeds the atrial pressure, forcing the mitral and tricuspid valves to close, meaning this happens in isovolumetric contraction period of the cardiac cycle. So this closure of the valve stops the forward flow from atria to the ventricles, causing sudden declaration of the blood and vibration of the surrounding structures, what you hear as S1. So where to hear it best? At the apex for the mitral component, which is louder, and lower left sternal border for the tricuspid component. So S1 is heard just before the carotid pulse is felt. So now let's discuss about why intensity of these heart sounds changes, especially when we are talking about S1. So loud S1. Always remember guys, the intensity of any sound, especially when we talk about S1 or S2 sound, depends upon how wide the valve leaflets are opened and how quickly they close. For example, if the valve leaflet is open wider, from this distance if it is closing, the sound will be louder. For example, if the valve leaflet is half open and from this direction if it is closed, the intensity will be less. So normally in physiological conditions, when I say that, when the valve leaflets are wider open, from they are covering the distance, and when they are covering the distance quickly and closing, in such conditions you will hear loud S1 in the physiological conditions. But there are some instances in pathological conditions also, you will see loud S1. Example, mitral stenosis as well as in the tachycardia. In these two instances also, you will see louder S1. Next one is the soft S1. In what condition the intensity of the sound will become less? In previous conditions, I told you that when the valves are closed quickly and from the wide opened valves. But in this condition, if the valves are closed slowly or they are already half or partially closed, and from this distance or from here if they are closing, obviously the intensity of the sound whatever is developed will be less. This is also maybe in physiological conditions, but in some pathological conditions, like examples like prolonged PR interval, or if there is a severe mitral stenosis, and if there is a left ventricular dysfunction, in these conditions also the intensity of the S1 is going to be decreased. So I am not going into more details because this is a physiology class, and separately whenever you study about the internal medicine, you will discuss the reason for each and every pathological condition in detail. What are the reasons which is responsible for the louder and softer S1. Now let us talk about the second heart sound, which is often referred as S2. So S2 heard at the end of systole and at the beginning of diastole. Or in simple terminology, we can say this is the systolic sound or diastolic sound. This is the diastolic sound because S2 signals the end of ventricular contraction or systole and beginning of ventricular diastole, that is the protodiastolic period of the cardiac cycle. So S1 is the systolic sound and S2 is the diastolic sound, because it is produced by the closure of semilunar valves, and closure of semilunar valves, that is aortic and pulmonic. So S2 has two components, A2 and P2. A2 component and P2 component both combine to become S2, right? So as the ventricular pressure falls below the atrial pressure in the protodiastolic period of the cardiac cycle, responsible for the closure of semilunar valves producing second heart sound. So What is the physiology in motion here? So blood tries to flow back into the ventricles, catching the valve leaflets and snapping them shut, setting these vibrations you hear as S2. So whenever the valve is closing, what is happening is the blood which is coming from the aorta into the left ventricle, it is trying to come to the left ventricle because of the gravity, and the wall is going against it, and when it is closing, there is a vibration which sets up, is responsible for the development of second heart zone. So where you hear it best? As I already mentioned, we have the two components. One is the aortic component and the pulmonic component. An aortic component can be best heard at the right upper sternal border, which is the aortic area. And the pulmonic component P2 is best heard at the left upper sternal border, which is the pulmonic area. Now, why intensity changes over here? So remember guys, whenever there is a louder S2, which means obviously there will be lot of resistance which is created in conditions like systemic hypertension or coarctation of aorta, and whatever may be the conditions where the pressure in the aorta will be much higher. And now, in what conditions you will see loud P2? Obviously, loud A2 develops because of more pressure in the aorta. So, loud P2 develops because of more pressure in the pulmonary artery. In the conditions like pulmonary artery hypertension, or maybe more flow towards the right side of the heart, maybe in the atrial septal defect, where there will be a high pulmonary artery pressure. So, any conditions where high aortic pressure or high pulmonary artery pressure responsible for the development of loud A2 and loud P2. Now, let's talk about splitting of S2. So, normally A2 occurs slightly before P2 because the right ventricle takes a bit longer to empty. This is the physiological condition only. Now, after finishing the second heart sound, now let us discuss about other heart sounds like S3, that is the third heart sound. And this third heart sound is also called as the ventricular gallop. So, S3 occurs just after S2 during early diastole, that is in the rapid filling phase of the ventricles. So, whenever I am talking about any of the heart sound, it is very important for you to correlate with which part of the cardiac cycle it is heard and what is the mechanism behind it. So, it is mainly caused when a large volume of blood hits a compliant or dilated ventricles. Compliant means physiological, dilated means pathological. So, when there is a sudden rush of the blood into the ventricles, producing a low frequency vibrations, because whenever the blood is coming from the atria to the ventricles, it hits the chordae tendineae, and this chordae tendineae vibration sets up, responsible for low frequency vibrations, can be heard as S3. So, let us talk about the physiological S3 as well as pathological S3 over here. So, physiological S3 is common in children, younger adults less than 40 years of age, conditions like pregnancy, as well as in athletes, because their ventricles are more compliant. Whenever the ventricles are more compliant, if S3 is produced, it is physiological. And in what conditions you will see the pathological S3? Pathological S3 indicates volume overload or systolic dysfunction. Examples like in the heart failure, enough blood is not pumped out, so blood always remains in the ventricle, and from that there is extra blood which is coming. It is responsible for setting up of the vibrations. Or there will be like mitral regurgitation. So in the conditions like aortic regurgitation and dilated cardiomyopathy, thyrotoxicosis, in all these conditions there will be an abnormal S3 or pathological S3 can be seen. Now, where to hear S3 at its best? So, bell of the stethoscope at the apex and patient is in left lateral position is the best way you can hear S3. So, now let's move on to the final one, which is the fourth heart sound, which is the atrial gallop. So, S4 is heard just before S1 during the later part of the diastole, right after atrial contraction, that is the atrial kick. Usually it is not heard, but if it is heard, so think that it is mainly caused by the atria which is forcing blood into the stiff non-compliant ventricle. Examples like maybe the ventricular hypertrophy or ischemic myocardium. So, now let us talk about the physiological as well as pathological S4. So, physiological S4 develops sometimes in elderly individuals due to milder ventricular stiffness. As age increases, you know that the ventricular wall becomes stiffness. On the stiffened ventricles, if the atria is trying to push more blood towards the ventricles, then there will be an atrial kick which is responsible for the development of S4, which can be heard in older individuals, we can say. And what is the pathological S4? The patient is not older. He is maybe around like 50 years of age or maybe 55 years of age, suffering from like systemic hypertension or any of the hypertensive heart disease when the ventricular become more stiff, or maybe in the conditions like aortic stenosis, the blood from the ventricle is not going out, so more blood gets accumulated inside the ventricles. In such conditions, or maybe in the conditions like hypertrophic cardiomyopathy, ischemic heart disease, or acute myocardial infarction, all these conditions you will hear pathological S4. Now, where to hear it best? With the bell of the stethoscope at apex and the patient in left lateral position, where you can hear S4. So, this is what we need to know everything in detail about physiology of heart sounds.